The SSRIs were considered a superdrug, very much like penicillin was considered a superdrug, a way to fight off infections caused by bacteria. The SSRIs, in fact, the first one was called Prozac, made it on the cover of both Newsweek and Time magazine. I know most of you don't see magazines very often. Everything is online. But at one time, they were all printed out and mailed. They became dominant because they had many fewer side effects and they were at least as effective as the tricyclic medications. Now, whereas the tricyclic medications block the reuptake of both norepinephrine and serotonin, the SSRIs tended to block that reuptake exclusively to serotonin. So suggesting that blocking the reuptake of norepinephrine may be causing some of the side effects. Now, these work. And there are several SSRIs, and just like the tricyclics, it isn't uncommon for someone to not respond to one SSRI, but respond to another. So if one doesn't work after 3 or 4 weeks of trial, the psychiatrist or physician may switch to another to see if that'll work. Now, there's controversy about the SSRIs, despite the fact that there's general opinion that these are miracle drugs in many respects. One has to do with an increased suicide risk, and there were some early lawsuits, especially among young people in their teens and early 20s, who, while taking Prozac, the first SSRI, showed suicidal ideation and in many cases actually did kill themselves, or at least attempted to kill themselves. And the argument that was made in court was that it was the drugs that made them suicidal. Now, we're going to talk about suicide later on, but let me tell you a little bit about suicide and depression. Most people would think that it's logical to assume that you're going to be most suicidal when you're most depressed. Or alternatively, as you're sinking into deep depression, you could be suicidal because you know what's coming. Suicidal is cyclical, so you feel yourself going down and you feel like there's no end in sight. You might be shocked to learn that you are far more suicidal as you are getting better. Your suicidal ideation, although present when you're deeply depressed, you're really not all that suicidal at that point. It's as you get better. Now, if a drug works, what's going to happen? You're going to get better. And since we know your risk for suicide goes up as you get better, okay, your risk of suicide will go up as you take the drug. But it's not the drug that's causing it, it's getting better. And in fact, we now know from several studies that have looked at this from several different directions, the increased risk of suicide has nothing to do with the SSRIs. People who aren't taking those drugs at all, but are showing improvement, have the same suicide risk as people who are showing improvement and are taking the drugs. Because this reduces depression, some people might argue that it may be taken too often. Well, it tends not to be overprescribed, unlike other drugs. Valium, for example, was one of the first anti-anxiety drugs, and frankly, it was prescribed largely because it was safe, almost like candy. It was the most widely prescribed drug in the world for a very long time, and it was immortalized in a Rolling Stones song called Mother's Little Helper. Prozac isn't a happy pill. None of the SSRIs are happy pills. They don't make you feel that much better. But if you're depressed, they tend to bring you out of the depression. But slowly, not quickly. Remember, there's at least a 3-week period during which this downregulation is occurring. So it tends not to be overprescribed. Most people don't stay on Prozac because it makes them feel better. They take Prozac when they need it and don't take it when they don't need it. Now, at least one psychiatrist wrote a book called Prozac Nation where he said, hey, this is a miracle drug and we would all be better if we took it all the time. I'll be real honest about that perspective. It's crazy. Why is it crazy? Because the human body and the human brain is unbelievably complex, and almost all of that complexity we don't understand yet. I mean, we know a lot, but compared to what we did know, but there's a lot more we don't know. And although we have developed drugs that have helped us to be able to fight off diseases and deal with psychiatric conditions like those covered in this course, they tend not to be terribly specific. The incredible balance in our body is the result of years, millions and millions and millions of years of evolution. The likelihood that we can match that in the laboratory requires an incredible level of arrogance. Okay, these drugs sometimes can make a difference, but they often have side effects and, well, probably other effects that we don't even recognize as of yet. It's a bit like using a sledgehammer to kill a fly. It'll kill a fly, but it'll probably do some residual damage, and I suspect that's the case here. Although I strongly believe in these drugs, and I know a lot of people whose suffering have been reduced as a result of the drugs. The idea that humans are smart enough to be able to control our brain better with drugs is so arrogant that I simply can't go along with that. Probably the most controversial of therapies for major depression is electroconvulsive therapy, or ECT, sometimes called electroshock therapy, EST as well. It's the same process. What you do is you put an electrode on either side of the brain and pass a fairly large current between the two. That triggers a grand mal seizure in the individual and seems to reduce the depression. Does it work? It actually does. And it's still used to this day, although it tends not to be used a lot because, well, there are less dramatic and effective ways that are available and less controversial as well. Modern ECT doesn't put the electrode on either side of the brain. It puts one here and one here. What part of the brain is affected in depression? It is the left prefrontal cortex. So instead of passing the current through the entire prefrontal cortex, we focus on the part that's affected. Also, the patient's anesthetized. They're under. They don't know what's going on. In the original ECT, the patient was fully awake, and they knew they were going to be shocked and that they would lose control and have a grand mal seizure. People have a grand mal seizure now, but you're given a muscle relaxant strong enough that instead of flailing around, sometimes so seriously that you broke bones, originally with ECT, it was common to have a half a dozen very strong guys holding the patient down to prevent the damage to the body from the seizure. What you see is a little vibration going through the body. Obviously, a seizure is going on, but the muscles are so relaxed that almost nothing is happening. Again, let me emphasize, the evidence is very clear. This tends to work. It tends to be at least as good as some of the other treatments we'll be talking about. Okay, by now, you're probably thinking to yourself, okay, electroconvulsive therapy works. But what maniac sat around one day and said, I know the way to treat people with depression. What I'm going to do is I am going to shock the hell out of their brain so they have a grand mal seizure and that'll cure them. That really is crazy, isn't it? So what you might want to ask is, where did this idea come from? it's actually a good example of science in action. One of the things about seizures is that it's unrelated to most other psychiatric disorders, such as the ones that we cover in this course. A seizure is a result of a brain problem, a neurological problem. And although there are neurological components to many of the disorders that we're talking about, they're not usually components that trigger seizures. So, schizophrenia is a severe disorder, and seizure disorder is a severe disorder, but they're unrelated to one another. Which means that if you have schizophrenia, you're either no more or less likely to have a seizure disorder. But you know, some people get really unlucky, and they have two serious disorders, a seizure disorder and schizophrenia. And on those rare occasions, when a patient with schizophrenia has a grand mal seizure, because they're subject to seizures, it was noticed that their symptoms went away. Their symptoms of schizophrenia went away for a few hours, sometimes up to 2 days. And so doctors wondered, hey, is there something about the seizure that perhaps resets the brain in some way? And might be a way of removing, not just for a day or two, but completely the symptoms of schizophrenia. So they would trigger seizures in patients that volunteered for this kind of treatment. Originally, they used insulin, which will put you in shock and then trigger a seizure, but unfortunately, it can also put you in a coma and you can die if you give a little too much insulin. Electric shock sounds barbaric, but it can be turned on very precisely. Its level can be very precisely controlled, and it can be turned off very quickly so that the risk is much lower, even though it seems like it should be much higher. Shock therapy did, in fact, improve the symptoms of schizophrenia, just like naturally occurring seizures did. But those symptoms came back, just like with naturally occurring symptoms. But just like it's possible to have a seizure disorder and schizophrenia, it's possible to have schizophrenia and depression. And in those patients who had both schizophrenia and depression, the seizures from electroshock therapy, electroconvulsive therapy, would relieve for a very short period of time the symptoms of schizophrenia, but would relieve the symptoms of depression for a longer period of time. And with repeated shock therapies, that period got longer and longer and longer. That's how we discovered that electroshock therapy was a viable treatment for depression. Again, a good example of science gradually figuring out a process. Now, let me repeat something I said in the previous slide. We still don't know how that works. We know that it works. But you know, for 200 years, we knew that aspirin worked, and we didn't have a clue how it worked. Although, interestingly, with aspirin, as soon as we figured out how it worked, within a decade, we had Tylenol, which was much less toxic to the stomach than aspirin. And we had Advil, which was a more powerful version of aspirin. Often, once we figure out how something works, we can quickly find ways of making it work better. Transcranial magnetic stimulation is another way of stimulating the left prefrontal cortex. What you see there is a woman who has an electromagnet that is over her left prefrontal cortex. And it's placed there because that's where the action, or more accurately, the inaction is in the brain of people who are depressed. Now, when your brain functions, it creates electrical signals which create a magnetic field. Magnetic fields and electrical stimulation are intimately related to one another. All electrical current creates magnetic fields, and magnetic fields can create electrical current. In fact, our entire electrical grid and most of the things run on are based on those concepts. So we measure brain activity by measuring the magnetic field on the surface of the brain, on the skull, with an EEG. And then we convert that back to an electrical signal that we can manipulate, amplify, and print out in some way. Here, what we're doing is we're creating a magnetic field outside of the skull to influence the electrical activity inside of the skull. This is showing promise. I won't say it's a mainstream treatment, but it is being heavily researched and it may very well prove to be a mainstream treatment at some point. There are other variations. Deep brain stimulation, especially in the Brodmann area 25, seems to be encouraging, but the problem is that is not something you can do on the surface. It requires an invasive procedure that most people, frankly, don't want to do. Similarly, the vagus nerve stimulation provides electroconvulsive therapy-like stimulation of a particular nerve, which seems to have a modest effect on depression. So we will continue to look for those ways of stimulating the brain through some sort of electrical response so that the brain functions in a more normal fashion and, as a consequence, reduces the depression. Earlier, we mentioned seasonal affective disorder. To remind you, this is a depression that comes on regularly every year for those individuals prone to it, usually in the late fall or early winter, and then goes away regularly, typically in the late winter or early spring. We've done a lot of research, and one of the things we know is that seasonal affective disorder is triggered by shorter days. And a lot of the depressive response is related to physiological changes in the body that are similar to what are found in animals that hibernate during the winter. So the whole body slows down. And often that seems to be related to depression. What we do to treat it is we trick the body into thinking that it's not winter, that we're not experiencing shorter days. And we do that by having the person expose themselves to a very bright light. The light has to be about the same brightness as the sun. And it has to be full spectrum in terms of all of the colors of the rainbow, just like the sun. If you get up early and you sit in front of such a light, your body thinks the sun rose. And at some point the sun will set, but if the sun rose 2 hours earlier, the day is 2 days longer, and so it's not winter. And as a result, you never slip into these depressions. If you're already in the depression, it triggers you into thinking that spring is here. Now, we use light like that in breeding animals because we'll put them in a place where there is no access to the sun and then control the lighting so that whatever season of the year we want, we can recreate it in the lighting patterns. This works, although I will say there's a problem with that picture right there. The picture suggests that the person is working at the computer with that light. The light is so bright that there is no way that the person would see anything on the computer. It would just wash out everything. So you wouldn't be able to read at a computer, but you certainly would be able to prevent the depression from coming on. So it essentially resets your biological clock so you think that it's a different time of the year. What about psychological therapies? Freud, of course, suggested that we're talking about a loss, either real or imagined, that accounted for the depression. So in order to lift the depression, you would try to bring out that loss and work with it, deal with it. Freud, of course, felt that much of the things we needed to deal with were in our unconscious. It took effort to get it into our conscious, because once it's in our consciousness, we can work with it. Does it work? Well, I don't think so. The truth is we really don't have much evidence for it, either working or not working. We do have more evidence for behavioral therapy working, even though at some level its model isn't any more interesting than the psychodynamic model. Remember, the idea from a behavioral perspective is that when you're depressed, you withdraw from people, and therefore you lose social support, and from the things you enjoy, and therefore you lose the chance to enjoy things again. So the treatment, as you reverse that process, the treatment encourages you to interact with people. Now, we all have friends, and they may be wonderful people, but they're high maintenance. They take a lot of energy. When you're depressed, you don't want to hang around those friends. Okay, it just takes too much energy and you don't have it. But we also have friends that when they walk in the room, we just feel better. And those are the people you encourage people who are depressed to hang around, to make an effort to, so that they can get social support. And we also encourage them to do things that they've done in the past that they love, but they aren't loving now because they don't get any pleasure from it. Now that takes a little bit of effort because it makes no sense to the client. You tell the client, okay, you love to go skiing and the weather's perfect to go skiing. You should go skiing because it'll make you less depressed. And they look at you and they say, but I don't love it now. I'm depressed. I don't love anything. But the fact is, and the evidence for this is strong, if you do the things you don't enjoy now because you're depressed, but did enjoy before you got depressed, you come out of the depression faster. It actually works, even though logically it shouldn't work at all. Just like there are several cognitive theories, there are several variations of cognitive therapy. Invariably, cognitive therapy is combined with behavioral therapy. So you try to get the person to change their behavior, but you also challenge their thoughts and get them to be aware of their thoughts. So, for example, if their automatic thoughts translate every mistake into I am worthless, I am a loser, I can't do anything right, they're probably doing those things without even realizing it. So you need to help them to realize it and to say, hey, wait a minute. I made a mistake, yes. Everyone makes mistakes. I feel like that means I'm a loser, but that's a crazy feeling. That's not logical. Logically, I get a lot of things right, and I only occasionally make mistakes. The one thing about cognitive behavioral therapy, and this was also true when we were talking about cognitive behavioral treatment for drug abuse, is that there's a focus on relapse prevention. Remember, in major depression, it's cyclical. You have a major depressive episode for a few months, and then a fairly long period where you're not depressed, and then another episode. What you want to do when another episode starts, remember there are reliable things like sleep disturbance that predict that the episode is developing. You want to jump on it right away. Your body says, I don't want to be around people. But you know that if you spend time around the right people, you're less likely to get depressed, or less depressed if you do get depressed. Your body says, I want to do things that were pleasurable because, well, they're not very pleasurable now. But if you keep doing them, you'll be less depressed. You know that your thoughts are going to really beat you up when you're depressed. Every mistake is going to be amplified. Everything you do right is going to be ignored. And you challenge those things because you know that that will help you to control the level of depression. Relapse prevention is jumping on a fortified treatment for depression that works long before the depression gets really deep. And in many cases, it prevents the depression from getting that deep. Now, how effective is cognitive behavioral therapy in relapse prevention? Well, the short answer is it's pretty effective. Now, relapse in major depression is going to occur. It's a cyclical disorder. But the longer you have between episodes, the more time you will not be depressed. And frankly, to someone who's depressed, having 4 depressive episodes as opposed to 8 over the rest of their life, that's a significant improvement. Now, this is a very complex slide, and I don't want to go into all of the complexity. What you have there are 5 bars in different colors that represent the rate of relapse at 10, 20, 30, 40, and 50 weeks, so up to a year. And what you can see is the relapse rates, which keep climbing over that time, rise to a pretty high level. Now, the first 2 sets of bars are cognitive behavioral therapy and traditional behavioral therapy without the relapse prevention measure. Both of them work in that the depression is often reduced, but relapse is fairly high. Now, why is it fairly high? In those first 2 sets of bars, we're looking at people who got depressed who also had parents who got major depression, and therefore we suspect they have a higher genetic load. Genes are contributing more. They're at a higher risk. Second 2 are individuals who don't have as high a genetic risk. The pattern is the same in both. When you add a relapse prevention component to the therapy, whether you have a high genetic load or not, it reduces almost by half the rate of relapse. And that's a pretty significant effect. This is a different study also looking at relapse. Here what you have are survival curves, so the more it drops, the more the relapse you have. The cognitive behavioral therapy that includes relapse prevention shows a significant reduction in the relapse, in this case over 2 years. I mentioned earlier that there's not a lot of research to suggest that psychodynamic therapy, traditional psychodynamic therapy, works very well. And what anecdotal data there are suggest it probably doesn't work all that well. Now, traditional psychodynamic therapy is long-term. Often you're in therapy for years. And your depression is probably going to go away during that period because depression tends to be self-limiting. But the amount of time you spend depressed doesn't seem to change very much. Interpersonal psychotherapy is a conceptual variation of psychodynamic therapy with 2 major differences. One is the focus is almost exclusively on your relationships with people. Almost exclusively. And the idea is that's most of your stress and most of your social support. If you have good people around you, you're going to get more social support and less stress. If you don't, you're probably not going to get that social support. The other thing is it's short term. If you see an interpersonal psychotherapist, after they complete the assessment, they'll say, okay, we're going to meet for 10 sessions over the next 4 months. And this is what we're going to focus on. But we're only going to do it for 10 sessions, so we really got to be focused every single time on it. This works, and it works at least, well, almost as well as cognitive behavioral therapy. Usually there isn't a relapse prevention component, but it works because, well, stress makes everything worse. Social support makes everything better. Improving our social relationships decreases stress, increases social support. So it definitely, by working around the edges at least, helps to improve depression. Now, they also deal with practical problems. You're going to lose some relationships. Okay, sometimes people die. But sometimes they move across the country. Or sometimes they get involved in other things and they don't have time to spend with you. So if you want to have good social relationships, you have to keep making new friends. And you have to work to make those relationships work for you.